Hi, good evening. I am Dr. Manoj Singhal. I am Director of Nephrology at Max Hospital, Vaishali. What we are going to discuss today is about hypertension, role of hypertension in chronic kidney disease. As we all know that hypertension is very common. It's seen in almost 40 to 50% patients who do not have renal disease, but in patients who have chronic kidney disease, the prevalence of hypertension is very high. More than 50% patients who have high blood pressure are in general not aware of their status. So there is a lot of unawareness about the blood pressure level in general community as well as in patients who have chronic kidney disease. Hypertension in itself is a very strong predictor of chronic kidney disease. If we look at the causes of chronic kidney disease, hypertension comes second as a cause of CKD after diabetes. Diabetes, of course, is the commonest cause of chronic kidney disease, but the second commonest cause is high blood pressure. If we look at the different stages of chronic kidney disease, as the chronic kidney disease progresses in its stage, the prevalence of hypertension increases. In patients who have early stage of CKD or what we call stage 1, hypertension is seen in around 35% of patients. In stage 2, it increases to almost 50% patients. In stage 3, 60%. And in stage 4 and above, almost 85 to 90% patients have high blood pressure. Hypertension, as I said, is a cause of chronic kidney disease. It is also a consequence of chronic kidney disease. Be it for any reason, patients who have chronic kidney disease, whether it is chronic glomerulonephritis, interstitial nephritis, or congenital kidney disease like polycystic kidney disease, all these patients will develop hypertension as the renal dysfunction progresses. So hypertension is cause as well as consequence of chronic kidney disease. In patients who are hypertensive, the renal dysfunction can occur predominantly with two reasons. There is an ongoing slow damage to the kidney, which we usually call benign nephrosclerosis. And in patients who have malignant hypertension, they at times can develop malignant nephrosclerosis, where there is a very rapid decline of chronic kidney disease, and these patients progress very fast to end-stage kidney disease. Benign nephrosclerosis, as has been described, it involves the vessel supplying the glomeruli, so afferent arteriole or arcuate arteries, where there is median hyperplasia and hypertensive changes in renal vessel, and consequently the glomeruli become more and more ischemic. There is less blood flow to the glomeruli. So gradually patients develop ischemic type of glomerular disease, which increases the renal dysfunction as these changes progresses. This type of changes progressive over many years. They progress over the period of 10 to 15 years and usually seen in patients who are around 60 or 70 years of age. Whereas malignant nephrosclerosis can occur at any age. Whenever there is an accelerated hypertension or malignant hypertension, that leads to fibrinoid necrosis of small and medium-sized arteries, and that leads to a lot of hormonal activation and ischemic changes of the kidney. So this type of glomerular disease can occur at any stage. It progresses very fast. Within 2 to 3 years, a lot of these patients, they reach end-stage kidney disease and require dialysis or kidney transplantation. Patients who have chronic kidney disease for any reason can also develop hypertension. As I said, hypertension may be a consequence of chronic kidney disease. For example, patients who have glomerular involvement or glomerulonephritis, most of these patients, they develop edema and hypertension at early stage of chronic kidney disease. Whereas patients who have chronic interstitial nephritis, where there is predominant damage to tubules and interstitium, they have salt losing type of nephropathy, and in these patients the onset of hypertension is slightly late, but in advanced stage, when they reach late stage of stage 4 or stage 5 where they require dialysis, almost 70% patients are again hypertensive in chronic interstitial nephritis. Polycystic kidney disease and other congenital disease, they can also develop hypertension in late stage. Even in acute stage, the surgical renal disease, for example, renal stones, kidney obstruction, infection in the kidney, trauma to the kidney, all these things can lead to high blood pressure in these patients. So hypertension can be seen in almost all type of kidney diseases. There are two mechanisms predominantly how hypertension leads to kidney disease. As I said, one is the preglomerular disease, where there is progressive narrowing or spasm of afferent arteriole or arcate arteriole that leads to glomerular ischemia, wrinkling of glomerular tuft, and collapse of capillaries, glomerular capillaries. And this type of ischemic nephropathy can develop in patients who have high blood pressure. Patients who have chronic kidney disease for any other reason, whenever they are hypertensive, there is loss of autoregulatory mechanism. So this high systemic blood pressure is transmitted to glomeruli. So there is hyperfiltration in the glomeruli, glomerular hypertension, hyperfiltration, and that increases glomerular sclerosis in these patients. So patients with chronic kidney disease, if they remain hypertensive, that hypertensive effect can be transmitted to the glomeruli and can lead to faster decline in glomerular function or kidney function. Besides this, there is other pathophysiological mechanism. Whenever there is high blood pressure, there is increased activation of sympathetic nervous system, there is increased salt and water retention, there is increased activation of renin-angiotensin system, and all these mechanisms work together to increase glomerular sclerosis and can lead to advanced renal failure in these patients. Whenever we suspect there may be chronic kidney disease, or for example, whenever there is hypertension is detected for the first time, there are set of investigations which are required. So at least the patient should be evaluated for secondary cause of hypertension. One has to carefully take the history of cardiac disease, endocrine disease, renal disease. One has to examine them very closely and do certain investigation, and especially urine routine examination and serum creatinine measurement. These are two simple tests which has to be done in every patient who is diagnosed to have hypertension. So if there is an abnormality in urine excretion of protein, or if there is blood in the urine, so if there is microalbuminuria or overt proteinuria or hematuria, that may indicate that patient may have renal involvement, and this hypertension may be secondary to renal disease. The other investigation is serum creatinine, and with that serum creatinine, one should evaluate GFR, glomerular filtration rate. And there are now a lot of formulas which are available. There are apps which are available. You can just plug in the value of age, gender, serum creatinine, and this formula will give you estimated GFR in that particular individual. And if the GFR is less than 60 ml per minute, that indicates that the patient has low glomerular function and should be evaluated for chronic kidney disease. So these are two basic investigations which are required to screen for chronic kidney disease in these patients. Coming on to the management of hypertension, first and foremost is what should be the target of blood pressure in these patients. So in all these patients, there are various reports and committees which have recommended different target, but more or less most of these guidelines have recommended the control of blood pressure to less than 140 by 90 millimeter of mercury. But if the patient has significant proteinuria or renal disease, our target is to the tune of 130 by 80 millimeter of mercury. In addition to the medical management, all these patients also require lifestyle modification. So first and foremost thing in blood pressure management is lifestyle. For example, relaxation exercises, regular walk, meditation, yoga, these things go a long way in control of blood pressure. One has to restrict salt because that's what increases the blood pressure. So there is impaired handling of salt in patients who have hypertension and renal disorder. So if one restricts salt in the day-to-day diet, that in itself is very helpful in controlling blood pressure. Number 3 is smoking. If somebody is a smoker, they have to stop smoking because every time we take nicotine or smoke, that increases blood pressure. Alcohol is another factor, or any other drugs like cannabis or afim and other drugs which some at times patients are taking. all these things can increase blood pressure. So counseling and lifestyle modification is the first treatment for high blood pressure. If the patient still have high blood pressure, one need to add medicine, and if the blood pressure is significantly high, one has to start at a time with 2 medications. So whenever we see a patients who have high blood pressure, we institute lifestyle modification, see if the blood pressure is controlled. If the blood pressure is still high, we add medicines. If there is any compelling reason for a particular medicine, if somebody has heart disease or CHF or any other reason, then appropriate medicine should be started. But in patients who do not have any compelling indication to start a particular medicine, patient should be started on ACE inhibitors or calcium channel blocker. These are the 2 medicines which are drug of choice in such patients. At time we have to start both of them if the patient's blood pressure is more than 100 or 110 diastolic, and then re-evaluate these patients for the control of blood pressure. Increase the dose of these medicines, and if the patient still have high blood pressure, one need to add diuretic to these patients. So third medicine usually added to the regime is the diuretic. When do we call it resistant hypertension? If the patient have uncontrolled blood pressure despite having 4 is diuretic, that's when we label this patient as resistant hypertension. Whenever we see such patients who have high blood pressure or resistant hypertension, one has to ensure certain things, and first and foremost is to ensure compliance. We have to counsel these patients again, talk to them and find out if they're taking their medicines regularly. We have to look into the lifestyle modification, if they are consuming a lot of salt, if they are consuming a lot of medicines or alcohol or tea or coffee. So that counseling is very important in these patients who have high blood pressure. One has to see the timing of medication. We at times have to distribute medications to morning or evening hours to give the round the clock or 24-hour control of blood pressure. We see the combination of medicine. If one medicine is increasing or antagonizing the effect of other medications, that has to be looked into. And if everything is controlled, then we look at like increasing the diuretics in these patients or adding another medicine which can control blood pressure in these patients. Patients who are on dialysis, who has advanced renal failure, again in these patients, the first and foremost cause is fluid and water overload. We have to counsel them again for salt and water restriction. There are guidelines from the panel of nephrologists, which is more or less same. We use calcium channel blocker, ACE inhibitors as a first line medicine, and then add beta blocker or diuretic as a second line medicine in these patients. To summarize, what I would say, hypertension is a very strong risk factor for chronic kidney disease. It may be a cause of chronic kidney disease or it may be a consequence of chronic kidney disease. But if hypertension is present along with chronic kidney disease, that has to be controlled, because uncontrolled blood pressure leads to very rapid decline in CKD and will lead them to advanced renal failure and dialysis. Whenever we see a patient who is diagnosed to have hypertension, always screen them for the presence of renal disease, and 2 simple tests, urine routine examination or urine for microalbumin and serum creatinine, are very helpful for screening for early stage of chronic kidney disease. In the management, one has to emphasize on lifestyle modification, which is very important in these patients, and if the blood pressure is still not controlled, one has to look into adding other medications to these patients. So with that, I will end my talk. Thank you.